Hello, in today's online lecture for pharmacological interactions, we're going to be looking at both cardiovascular and renal drugs. The reason these are grouped together is because, as you'll see, conditions related to the cardiovascular system that are treated with drugs often target the kidneys. We'll look at antihypertensive drugs, diuretic drugs, and antiarrhythmic drugs. Heart disease is a very prevalent issue, and while lifestyle modification should be the inevitable prescription, it isn't always enough. Any slides that have background info written on them are slides that you don't need to explicitly study all the details of, but you just have to have a general understanding because it will be pulled into and really pulled into other concepts in this course, but it's also important that you have that sort of general language and understanding of normal anatomy and physiology as well as some of the altered states. This slide is demonstrating that cardiovascular function is really an integrated network of many other systems, including the nervous system, the renal system, the heart specifically, and the circulatory system. The nervous system, remember that our heart has this intrinsic control via the SA node, sinoatrial node, or the pacemaker, and it sets the pace. It's an automatic function. It's not relying on the central nervous system for its main baseline. But the central nervous system, specifically the autonomic nervous system, which you might remember involves the sympathetic and parasympathetic systems, these can provide an additional control to sort of fine tune the heart depending on what is needed in the body. So the autonomic nervous system can then have effects on the heart and blood vessels, the kidneys, as well as the adrenal medulla, which is part of the adrenal gland that sits on top of the kidney, all of which contribute to cardiovascular function. The kidney or the renal system, the kidneys are also involved in cardiovascular function, and this has a lot to do with the control of sodium and other ions and water, which can then determine what a person's blood pressure is and their overall cardiovascular function. One important thing to always remember is that blood volume will determine blood pressure. The more volume there is within the blood vessels, the greater pressure there will be. So if you think of a balloon that you fill with water, and if you put a little bit of water in that balloon, there's not a whole lot of pressure against the walls of the balloon. But as you increase the amount of water you put in the balloon, it starts to stretch out and there's an increase in pressure. So volume then will dictate pressure. Looking just specifically at the heart, any changes in force of contraction and the frequency of contraction is going to affect how blood is moving and reaching certain tissues. So when we look at the left side of the heart, if you change force and frequency of contractions, it changes how much blood leaves the heart and how it reaches tissues. With the right side of the heart, same thing, change in force and frequency of contractions is going to impact how that blood moves to the lungs to be oxygenated. The circulatory system, when we talk about this, we're not just talking about the volume of blood that's there, but also the composition. So changes in the amount of water, the amount of electrolytes, proteins, and so on and so forth will affect overall cardiovascular function. So when we talk about cardiovascular and renal pharmacology, you can see that it does require this integrated understanding of how the nervous system and the kidneys and the heart and the blood all interact. And drugs are going to target different points along these interconnected pathways. Let's overview blood pressure. First reminder has to do with your systemic veins, which hold the majority of your blood. They're considered the greatest reservoir or major reservoir for blood. So it just means that they can hold a lot of blood and adjust our body's circulation depending on what the needs are. But this is a very low pressure system, and it makes sense because blood is returning back to the heart. So we're having lower pressure here because blood is just returning to the heart, whereas this is under higher pressure to deliver it to the organs or the tissues. Now, looking at arterioles, this would be the main site of resistance within the systemic circulation. And that's because the arterioles, the small arteries, they have this ability to change their diameter quite extensively, anywhere from 4 to 25 micrometers. And because flow depends strongly on that vessel diameter, if you change the diameter, blood flow can change up to 256 times. So that's huge. Arterioles are regulated by local chemical signals and nerve signals so that the body can adjust blood flow to where it is needed the most. The point of this equation here is determining blood flow. All you need to be aware of here is that the key idea is that blood flow is going to be dependent massively on vessel radius, and that's shown where you have r to the power of 4. Even a small change in the diameter of a vessel can create huge effects on flow. So if I draw that out, if we're looking in a vessel here, that's the diameter, and then you have the radius of it. If you increase the size of that vessel, what we have is a blood vessel where more blood is going to be able to move through this, less blood is going to be able to move through this. So changing the radius, creating widening versus narrowing, will change the flow. And so this happens extensively at the level of the arterioles and determines the main resistance. So the more narrow it is, the more resistance there's going to be. Think of the heart pumping blood through a small vessel versus a large vessel. How much easier it is going to be for blood to move through here. All right, so this area here is just what I've mentioned already, reminding you how much blood is in the systemic circulation. And then these diagrams or graphs here show you changes in blood pressure as we move from arteries to veins, changes in diameter as we move from arteries to veins, specifically in this case from arteries down to capillaries, back up to the vena cava, and the total cross-sectional area as you move from one to the other, as well as the movement of blood, how fast velocity blood moves through vessels depending on what vessels they're at. You can see it really slows down here, which is where we want absorption to occur. Now, looking at hypertension, this is a slide that I would like you to be aware of. When we talk about hypertension, we're talking about high blood pressure. There are two main types, primary or essential hypertension and secondary. Primary is the most common, with about 92% of cases. You don't need to know this number, but just be aware that it is the most common. And there's no identifiable cause when we talk about primary hypertension, but it is something that's chronic and, if untreated, can be progressive. It tends to be more common in certain populations and is considered to be something that can be treated but not cured. The reason that is said is because even if somebody makes lifestyle changes, so if somebody's diagnosed with high blood pressure, even if they make lifestyle changes, they are still potentially prone, so that tendency towards high blood pressure remains, but it can be controlled with things such as lifestyle changes as well as pharmacological intervention. Okay, secondary hypertension. This type has an identifiable cause. That's the secondary component. So, for example, it could be somebody that has chronic kidney disease or even chronic kidney failure. That's chronic renal failure. And the good news here, though, is that if you treat the underlying cause, the high blood pressure can sometimes be reversed. So the goal of treatment is going to be keeping blood pressure below 140 over 90 millimeters mercury, or even less if a person has existing conditions, such as if somebody has diabetes mellitus or if they have chronic renal failure, it might be advisable to keep it even lower than that. When we look at blood pressure, oftentimes you think of 120 over 80 as being what is considered normal. The 120 part, so the top number is, or in this case 140 or 130, is systolic. That is the pressure within the arteries when the heart contracts. The bottom number, in this case 90 or 80, this is the diastolic pressure, and it's the pressure in the arteries when the heart relaxes. Normal is considered with systolic less than 120 and less than 80 for diastolic. Elevated is just above that. And then hypertension will be diagnosed in stages. So here we have early hypertension. And then once we get to 140/90, this is where you're definitely getting into a concerning stage of hypertension that should be addressed. And then, of course, anything higher than that is much more concerning. Why is it concerning? Well, somebody that has untreated hypertension, it can lead to serious problems. It can lead to heart disease, including myocardial infarction, so heart attack, heart failure. People with high blood pressure can experience chest pain. Talked about angina. It can lead to kidney disease, stroke, among many other things. So it needs to be addressed immediately. Now, clinically, what matters more? Is it the systolic number or the diastolic number? Well, both do matter because high systolic and high diastolic pressure are linked to heart, brain, kidney damage. But in younger people, so we'd say maybe less than age 50, diastolic blood pressure is a stronger predictor of risk. Whereas in older adults over the age of 50, systolic blood pressure becomes more important because the arteries stiffen with age. There's a condition called isolated systolic hypertension, and this is where somebody might have, let's say, their blood pressure is 160/70. The systolic is high, but the diastolic is not. This is actually more common in the elderly, and it is considered a major risk factor for stroke and heart disease. A little bit more on hypertension, but this is a background slide, so you don't need to know all the details here. We need to first define what is or what determines arterial pressure. Well, it's a combination of cardiac output. Cardiac output down here is defined as stroke volume. So this is the volume of blood pumped out with each stroke or pump, multiplied by your heart rate. So this, when we talk about cardiac output, it's the amount of blood that is leaving the heart per beat over a specific period of time. It might be, say, 1 minute. And so arterial pressure then is determined by cardiac output and by peripheral resistance. Peripheral resistance, just simplified, is the resistance that the blood is going to face as it flows through the smaller vessels, in particular those arterioles, those small arteries that I described earlier. So think of peripheral resistance is like how water would flow through a narrow pipe. It's going to meet more resistance than water flowing through a wide pipe. In terms of the systems that help regulate blood pressure, we're going to elaborate on some of this on upcoming slides, but we have sympathetic baroreceptor reflexes, renin, angiotensin-aldosterone systems, and renal regulation of blood pressure. Don't worry about this very busy diagram, but you can just see how much is involved in maintaining homeostasis when it comes to blood flow throughout our body. And a big role player is going to be neural mechanisms, so nervous system, and endocrine, so hormones that will contribute to this. Now that we know what hypertension is, let's talk about how we treat it. So the overall therapeutic goal should be obvious. It's going to be to lower blood pressure below that 140/90 millimeters mercury. The main target is usually going to be systolic pressure. And that's because oftentimes the diastolic pressure will oftentimes improve once the systolic one is under control. Usually, you're going to begin with one drug, and that's considered monotherapy, mono being one. If blood pressure isn't controlled after one drug, then a second or even third drug can be given, each one really working through different mechanisms. The common first-line choices are thiazide diuretics, angiotensin-converting enzyme inhibitors or ACE inhibitors, angiotensin receptor blockers or ARBs, calcium channel blockers, long-acting, beta blockers, and then single pill combination. We're going to be talking about these throughout today's lecture, so we will elaborate on these coming up. What I did want to mention though is the single pill combination part. So sometimes a single pill combination that contains 2 drugs in 1 tablet is given, and this improves compliance because then patients only have to remember to take 1 pill at the same time every day. Non-pharmacological interventions can be just as effective as medications in lowering blood pressure, especially important for prevention. So obviously it's better to not make poor lifestyle choices from the beginning that cause a lot of the problems that come up, but they also can be effective in helping improve health issues once they've started. So some examples include a healthier diet, exercise, weight loss, cutting down on salt, reducing alcohol, managing stress, quitting smoking. And the advantages of all of this is it's very safe and there's no drug side effects, but it's harder for people to stick with in the long run. I'm sure you've heard that sodium is not good for blood pressure, but why is that? Well, when you consume sodium into your diet, it gets absorbed into the bloodstream. And when it's in the bloodstream, it creates this osmotic force that pulls water into the bloodstream. If you pull water into the bloodstream, you increase the amount of volume within the blood vessels, which therefore increases pressure because of that relationship between volume and pressure. Here's a nice list of health behavior strategies that can help both prevent hypertension, but also assist with treating it or managing it. Being more physically active, reducing weight, reducing alcohol intake, eating healthier, a DASH-like diet. DASH would be stands for Dietary Approach to Stop Hypertension. This involves what you would expect in a healthy diet, lots of fruits and vegetables and low-fat dairy and lean protein, that sort of thing. And really, this should be prescribed for people without hypertension, but also with. And relaxation therapies and quitting smoking. A lot of obvious strategies, but these, while obvious, are very hard to implement in terms of patient compliance. Now let's look at antihypertensive drugs and some of the major classes. They can be grouped according to whether they decrease blood volume, reduce cardiac output, or reduce vascular resistance, all which will then reduce blood pressure. We'll talk about these on upcoming slides, so this is really an overview, but when we talk about decreasing blood volume, we know that if there's less volume of blood in the vessels, that means less pressure. If we're reducing cardiac output, if we're putting out less blood into the blood vessels, that's less volume and less pressure. And then with reducing vascular resistance, this just has to do with how sort of narrow or wide the blood vessels are, which changes how much blood is held within them, and therefore how much pressure is exerted against the vessel walls. First, a little bit of background on renin-angiotensin-aldosterone system, or RAAS. This is a system that is going to work at regulating blood pressure, blood volume, and electrolytes. So it's working to maintain homeostasis in the body, but ultimately what it's doing is increasing blood volume and therefore increasing blood pressure. So we're talking under it working under normal circumstances. But where it all starts is with some sort of stimulus, and the stimulus is going to be detected by, remember those macula densa cells that are in the distal convoluted tubule of the nephron? Well, these are going to be sensitive to increases in potassium, decreases in sodium, decreases in blood volume, and decreases in blood pressure. It will detect, all right, homeostasis is off balance. Let's activate the RAAS or the RAA system and bring blood pressure or homeostasis back to normal. So what happens first is the kidneys are going to be signaled to release renin. Renin will then convert angiotensinogen, which is made by the liver, into angiotensin 1. At the level of the lungs, angiotensin 1 is going to be converted into angiotensin 2 by angiotensin converting enzyme, or ACE. Now, what are the effects then of angiotensin 2? Angiotensin 2 causes vasoconstriction, or we can say it increases systemic vascular resistance, which will increase blood pressure. Now, what does that mean? Well, let's say here's the heart, and then we have a blood vessel here. This is representing systemic blood vessels. With the help of angiotensin 2, the systemic blood vessels are going to narrow or constrict. What normally could flow through here is now going to be met with some resistance against the walls because we have the same amount of blood moving through a more narrow space. This causes, if you can sort of picture it, the blood to sort of back up. So what we see upstream is this increase in the volume of blood and therefore pressure. This is what contributes to an increase in blood pressure, helping to maintain the normal blood flow throughout the body to meet needs. The other thing that is done by angiotensin 2 is going to be the stimulation of aldosterone from the adrenal cortex. Aldosterone is going to act on kidney epithelial cells, okay, so cells of the kidney, increasing both the production and insertion of a specific type of pump called a sodium-potassium ATPase pump. It's going to insert these into the kidney. And what this is going to allow for is an increase in sodium reabsorption and an increase in potassium secretion. In other words, the big thing is going to be increasing the amount of sodium that we reabsorb into the blood, getting rid of excess potassium. This is a typical normal ratio. And what this will do is increase blood volume because water will follow sodium into the blood, which will increase blood pressure. And in case you're wondering, the reason that there's a reduction in potassium when we have an increase in sodium reabsorption, the reason for that is to maintain the appropriate electrical gradient. Looking over at this image, a couple of things I want to point out. I said that aldosterone stimulates the production of sodium potassium ATP pumps. So here's aldosterone. This is a mineral corticoid receptor, ends up stimulating the production of these sodium potassium channels. So you can see them being produced, migrating to the surface or to the plasma membrane and inserting themselves. And also you can see the epithelial sodium channels that are being produced by aldosterone and permitting the reabsorption of sodium. So bringing it back into the blood. The final thing I wanted to mention on this slide is just a helpful reminder of what angiotensin actually means. Angio refers to blood vessels. If you remember learning about angiogenesis, it's the production of new blood vessels in the body. So angio is blood vessels, and then tensin, think of tense. So angiotensin is going to cause vasoconstriction, tense blood vessels. Now, looking at drugs that would manipulate that renin-angiotensin aldosterone system, we would call these antihypertensive drugs because they are trying to return blood pressure to normal. There are 4 listed here: direct-acting renin inhibitors, ACE inhibitors, angiotensin receptor blockers, and aldosterone inhibitors. I'll tell you right now that you will not be tested at this point on the names of the drugs on this slide, on this particular slide. There are some drugs you need to know, but these ones you do not right now. But what I do need you to know is the 4 different types that are listed here. Now, for the most part, the name tells you what it's doing. Direct-acting renin inhibitor is going to block that very first step. So less angiotensin 1 is even going to be made. So we don't end up with that end result of vasoconstriction and sodium reabsorption. ACE inhibitors, this will stop the conversion of angiotensin 1 to angiotensin 2. So here we have ACE, which converts 1 to 2 at the lungs. We're going to block that step. Angiotensin receptor blockers. These are going to block angiotensin 2 from binding to its receptor and creating the effects that it is meant to create. Aldosterone antagonists or inhibitors, these are going to stop the effect of aldosterone, making the kidneys excrete more salt and water rather than retaining it, which is normally what aldosterone does. I'll talk more about this later, but I would like you to make note that these drugs right here, which we can just class as aldosterone antagonists or inhibitors, these are potassium sparing diuretics, but we'll come back to that. This is a nice summary table showing you what we know happens with RAAS activation, which I talked about on an earlier slide. And when we're trying to manipulate or inhibit the normal effects in order to bring blood pressure down, we see really the opposite effects occurring. An overactive RAAS can cause harmful changes such as remodeling of the heart and cardiac hypertrophy. The reason for that is because if the heart has to work harder, it will eventually remodel and get bigger to do its job properly, which is considered pathological. So blocking this system helps protect the heart and kidneys long term in certain situations. All right, another background slide looking at renal system overview. So what's happening at the level of the nephron. Remember the three main steps of urine formation starts with glomerular filtration here, reabsorption, primarily through here, but also at other areas, and then active tubular secretion. Starting with filtration, this happens at the glomerulus. Almost everything that's small, so we're looking at things like sodium and glucose, amino acids, urea, water. This stuff is all going to be filtered very easily through a healthy glomerulus. Larger proteins and things like blood cells, those are going to stay behind. After filtration, so once we have substances now in the tubule system of the nephron, reabsorption is going to occur. About 99% of the water, the electrolytes, and the nutrients that were filtered and end up here end up being reabsorbed back into the bloodstream. So the kidneys are very selective. It's not going to just throw everything away that it receives. And when I say throw away, I mean ending up as part of the urine. It's going to take most of it back. And this helps keep our body in homeostasis. Now, if we look at the different levels, so in the proximal convoluted tubule here, this is where the majority of reabsorption is happening. So you have, about 65% or so of sodium that's actively reabsorbed here. In other words, it's put back into the blood. So it leaves the tubule system and goes back into the blood. And then, of course, water is going to follow sodium just because of osmosis. So this is also where a lot of water is reabsorbed. Potassium is also going to be reabsorbed in large amounts here. And then chloride tends to tag along with sodium. Remember those two terms together, sodium, chloride. So think of the proximal convoluted tubule as really this bulk reabsorber. Moving on to the loop of Henle, or Henle, depending on who's saying it. This is where about a quarter or so of sodium is going to be reabsorbed along with chloride. About 15% of water, so less than what we saw at the proximal convoluted tubule. And then, of course, some potassium. But this is where the body or the nephron is getting ready to start concentrating the urine. Now into the distal convoluted tubule. This is where reabsorption becomes more fine-tuned. Only a small fraction at this point of sodium is going to be reabsorbed. And this is actually an active process, so it has to be actively reabsorbed back into the blood if it's going to move. Water reabsorption here is going to depend on hormones. Remember, antidiuretic hormone. If antidiuretic hormone is present, then these water channels can open and allow water to be pulled back into the blood. So without ADH, water will remain in here and end up being part of the urine. Whereas when ADH stimulates this area, then it allows for water to leave. Potassium at this level can also be secreted, meaning put back in. And why do we put it back in? You can see there's also hydrogen ions and ammonia. The reason we do this is to maintain electrical charges, to keep our body in homeostasis, and also to maintain the proper pH of our blood. And then finally, in the collecting ducts, this is where you see some more hormonal influence or hormonal control. A very small amount of sodium is going to be reabsorbed, and this is going to depend on aldosterone. So remember, aldosterone is going to stimulate this part of the nephron to encourage sodium reabsorption. Water reabsorption is going to be occurring here as well, but it's going to be controlled by ADH, so antidiuretic hormone again. And the beauty of these hormones is they allow us to hold on to more water into our blood when we are dehydrated, or get rid of more water if we're overhydrated. So think about if you haven't had anything to drink all day long and then you finally go pee and it's sort of this bright yellow. Well, it hasn't been overly diluted with water. And the reason for that is because your body's trying to hold on to it. Whereas if you're drinking a significant amount of water throughout the day, you'll notice that your urine is a clearer color, and that's because your body's trying to get rid of that excess water. And so it dilutes that urine or dilutes the color that you would see. And so those hormones, ADH and aldosterone, play a big role here. So a few important things to just point out before we move forward. One is going to be the role that sodium and potassium have when it comes to our blood pressure. And we'll look at drugs that can impact that soon. But I do want you to make a mental note that sodium, we see most of it taken back in the proximal convoluted tubule and much less towards the end. We also see that potassium, we reabsorb a lot in the proximal convoluted tubule, but then what's interesting is we add it back via secretion. So at this distal convoluted tubule, we are adding potassium back. So we get rid of it from the tubule and back into the blood, then we add it back in. And what this recycling does, it'll become important for you to understand this soon, is helps us maintain a particular electrical charge within the nephron. And then, of course, the influence of aldosterone is also going to be very important at the level of the collecting duct. All right, let's dive into drugs now that can be prescribed for patients with hypertension or high blood pressure. The type of drugs are diuretics. There are 4 that we're going to look at: osmotic diuretics, loop diuretics, thiazide diuretics, and potassium-sparing diuretics, also called aldosterone antagonists. Diuretics are drugs that are going to help the body get rid of extra fluid, and it does this by increasing urine production. And so you can see the relationship there between cardiovascular system and the renal system when we talk about drugs. So as a result, what do we see when we get rid of more fluid in the urine? There's a reduction in blood volume. And what does a reduction in blood volume lead to? A reduction in blood pressure. This is a great overview summary slide, but we're going to look at these independently coming up. Starting with osmotic diuretics. A great example of an osmotic diuretic is mannitol, which I would like you to know. Mannitol is given intravenously and it goes straight to the kidneys. It goes straight to the kidneys and it's filtered freely by the glomerulus. That's its entry point into the nephron. So it has to be able to get there in order to do its job because it's not working in the bloodstream for these purposes. It's working in the nephron. Okay, so it must enter the nephron to work. It's not reabsorbed, and that's really the magic of mannitol. Unlike most substances where once it goes in, a lot of it is reabsorbed back into the blood. But with mannitol, it isn't. It doesn't. It stays. So it sort of hangs out like an unwanted guest in the proximal convoluted tubule and the descending limb of Henle. So where that would be this area, or on a more realistic diagram would remain here. So how does it work? Well, hence the magnet emoticon here. It is going to really act as this osmotic force, and it pulls water in with it by osmosis. So in other words, mannitol is hanging out here and can't get out. And then water says, oh, I want to be where mannitol is, because water's such a follower, and follows mannitol into the tubule. What does that do? Well, the water wants to stay because it really, really likes water, or really, really likes mannitol. And this then increases urine volume. It also increases urine flow. So it's moving faster now through the tubular system. And so because of all this water rushing in, there's not really a whole lot of time for sodium now to be reabsorbed and therefore take water with it. So we get this pretty decent reduction in both sodium and water reabsorption because it's now becoming part of the urine. So because mannitol does cause major water loss and taking sodium with it, it can lead to dehydration and hypernatremia. Hypernatremia refers to high amounts of sodium in the blood. And you might be thinking, well, wait a minute, but we're getting rid of some sodium. Well, it's mainly because of how much water we're getting rid of. You get rid of so much water that the sodium that is in the blood becomes more concentrated because there's less water. You can think of the blood almost becoming more salty. So you have to be cautious of that when prescribing these drugs. Here's a good little example here showing you this is the tubule of the nephron here, where urine would be. So this is the inside part here. This is the cell, the epithelial cells that actually line and make up the tubule system. And then this is the blood. The blood would be outside of it. That's what we would take water and sodium back into in most cases, in normal cases. But what we can see happening, mannitol hangs out in the lumen. Water, being a follower, is drawn in by osmosis, ultimately reducing blood volume and blood pressure. This is showing you where osmotic diuretics tend to work. And later we'll be talking about the other forms, and you can see they work at different areas of the nephron. The final thing I wanted to mention is that mannitol is considered to be pharmacologically inert. What this sentence means is that it does not interact, mannitol that is, mannitol does not interact with receptors or transporters. What that means is that it is purely an osmotic mechanism. It's not changing how transporters directly function. It's not blocking them. It is purely working as an osmotic agent, like a magnet, drawing water into the tubules. Moving on now to talking about loop diuretics. Loop diuretics are going to act on the thick ascending limb of the loop of Henle. So let's just move back for a moment. Loop diuretics are going to work on this ascending limb here of the loop of Henle, but the thicker part. So this is the thinner part. This is the thicker part. So we're on the second type of diuretic. And when we look at the thick ascending limb, that's important because this is where we get normally about 25% of sodium reabsorption. And so that means if you can block reabsorption here, you can block 25% of sodium reabsorption. So let's just go back here for a moment. At that loop of Henle, you're going to get about 25% reabsorption of sodium. So if you can block this from happening here, then you get a reduction in sodium moving back into the blood or being reabsorbed, and water, therefore, not following it because it's not there. Loop diuretics are especially helpful when somebody's renal function or kidney function is reduced, and they have this ability to work pretty quickly. Now, one of the negatives is it can cause hypokalemia, a reduction in potassium in the blood, and a reduction in calcium in the blood, and potentially a reduction in magnesium in the blood. And I'll explain why that is soon. The example that I would like you to know that is a loop diuretic is furosemide. Let's look at the pharmacodynamics, and that's really the mechanism of action, and that's what was listed here as well. So what exactly is the drug doing to the body? I'm going to zoom into this really great diagram. Again, here's the lumen of the tubule and the nephron. So this here, it's like the inside of a hose right here. Then this is the lining of the hose, which are the epithelial cells of the tubule. And then this is the blood. Normally, so talking about normal circumstances right now, there is a pump that exists within the epithelial cells of the tubule cells of the kidney. And it's listed here as being called the NKCC2 cotransporter. What that just means is it is a sodium, potassium, and 2-chloride transporter. You can see that what this transporter would do under normal circumstances is move sodium, potassium, and 2-chloride into the epithelial cells. Now from here, two things happen that are relevant. One is the sodium would then be actively pumped in exchange for potassium back into the blood. And when this sodium goes into the blood, it's going to draw, it's not shown here, but draw water with it, which would then increase blood volume and blood pressure. The other thing that's important for you to know is that when potassium is pumped in here, what it does, and I mentioned this earlier, is it is then going to, along with what's pumped in, go back into the lumen. Why does this happen? Well, I mentioned earlier that this recycling of potassium pumped out and brought back in, what that does is allow for maintenance of an appropriate electrical gradient relating to that positive charge. So you might be thinking, well, why are we pumping it out if it's coming back in anyways? Well, if you leave it here in the lumen, it's going to end up as part of the urine. So if you want to keep a positive charge in this lumen here, and again, we're at that ascending limb of the loop of Henle, you pump out the potassium and then you bring it back in, keeping that positive charge. Another normal thing that's happening is that any calcium and magnesium that we want to hold on to can actually just move in between the cells here and go back into the blood. Note that magnesium and calcium are also positively charged. And the reason that they are encouraged to leave is because that potassium keeps it positively charged in here to begin with, so they don't need to contribute to that positive charge, and they leave and go into the blood, and they're going to be used for many different functions in the body, good for, of course, bone health and muscle contraction and nerve function. We've talked about this in previous lectures. So that's what happens under normal circumstances, but of course, this is not a normal situation. But you have to understand it to understand what happens when drugs are administered. Let's say somebody is given now a loop diuretic, okay? What's going to happen is that loop diuretic is going to block this. Now, it's not a true blocking of the receptor like we've talked about. You're not really blocking the main site or an allosteric site in this case, but there's an area that's being blocked that impacts the function of this pump. And if this pump is not working, well, that means that sodium, potassium, and chloride are not going to be able to get into the cell. And so it stays instead in the urine. This has a couple of implications. One is going to be the positive one because of the purpose of the drug, which is if we keep sodium here, we end up losing sodium in the urine and water will follow it. So a reduction in sodium and a reduction in water means a reduction in blood volume and a reduction in blood pressure. But one of the other things that happens that is really a side effect has to do with hypokalemia. Hypokalemia is low potassium in the blood. Why we see that happening is because potassium here normally would move through here and then be recycled in. But now because it's staying here and being lost in the urine, now there's less available to be recycled and be brought in. So what happens? Well, there's a change in the net charge in here because we're adding less of those positive ions, those cations. So what does that mean? Well, calcium and magnesium, which are hanging out here in the lumen right now and would normally be encouraged to go into the blood, they're going to be thinking, well, the positive charge is changing. Maybe I should stay here to help maintain that charge. And then they end up remaining there too long and they end up being in the urine, being a part of the urine. And so if we're getting rid of calcium and magnesium, now we're in a situation of less calcium available in the blood and less magnesium available in the blood. The other thing I wanted to mention is the term divalent loss. Divalent loss refers to the loss of ions that carry a double positive charge, and that would be calcium and magnesium, the loss of these in the urine. And so loop diuretics then can cause divalent loss. The final thing I wanted to mention is an additional risk of the use of loop diuretics, and that is hypokalemic metabolic alkalosis. The basics of this is that when someone is on a loop diuretic, we know that the body's going to be increasing the amount of sodium that's excreted in the urine. And of course, this is all really happening at that ascending limb. So eventually, the body starts to think, and this can happen in the latter part of the nephron, the body starts to think, okay, well, we're losing way too much sodium. Let's take some back. And in this process of taking some sodium back, it's exchanged for hydrogen ions. The hydrogen ions then will go into the urine, and the sodium will be pumped back into the blood, and then there will also be an exchange of potassium because we will exchange sodium for potassium in order to get it into the blood. So this causes further loss of the potassium, but the big thing to mention here is the hydrogen ions that end up in the urine make the blood less acidic, and that will increase the blood pH. So as we lose these hydrogen ions from the blood becomes more basic. And so the person can end up in a state of metabolic alkalosis, which is very dangerous. Sort of a failed compensatory mechanism. So I know that was a lot of information, but I just wanted to give you a quick summary of what I just spoke about, sort of all of this together. Loop diuretics are going to block this NAKCC2 pump, keeping sodium, potassium, and chloride in the urine. The effect that's seen here is that one, sodium will be part of the urine and water will follow it, so it gets rid of excess sodium and fluid within the blood vessels, bringing blood volume and blood pressure down. The other effect that we see is that potassium can no longer go into the epithelial cell of the tubule and be recycled back in to maintain the positive charge. So then calcium and magnesium don't naturally want to move. It's called paracellular in between cells, naturally move in between cells into the blood. They hang out here to try to maintain that positive charge at the membrane and then eventually end up being lost through that divalent loss in the urine. Then, as the body tries to compensate for this excess loss of, in particular, sodium here, later on in the distal tubules, it starts to say, okay, well, why are we losing so much sodium? I mean, it didn't get the memo about the loop diuretic and the purpose of the person being on it. So it says, okay, well, let's try and take some sodium back at this level instead. And when it takes sodium back into the blood, it does this in a kind of two-step process. One, it's pulling sodium in and exchanging it for hydrogen. And then in order for sodium to then get into the blood, it has to be exchanged for potassium. So what we end up with is loss of both potassium and loss of hydrogen. The loss of hydrogen is problematic because it maintains the pH within the blood. So if we lose those hydrogen ions, the pH goes up, which is alkalosis, or the blood becomes more basic, leading to the term metabolic alkalosis. Now, all of that explanation with this great diagram is pointing to these two bullets. The third benefit or effect that you would see with a loop diuretic, which has the goal of getting rid of excess fluid to bring blood pressure down, is inhibition of the macula densa cells. Thinking back to normal anatomy, this here is a nephron that has been stretched out so that you can see each part, the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and the collecting duct. Normally, though, it would sort of be all squished together and wrapped around each other, and you're going to have this part actually in close proximity to this part, the way that it's sort of folded. In the distal convoluted tubule, we have these macula densa cells. So here's the distal convoluted tubule, blue structure, and these cells here are macula densa cells. These cells, when fluid passes through them, these cells are going to pick up the amount of sodium and chloride that is in that tubular fluid, sodium being what's relevant right now, or mostly relevant. In normal circumstances, if it notices that there is an increase in the amount of sodium, I'm just going to do plus to represent increase. There's an increase in the amount of sodium here. It starts to think, well, we're getting rid of far too much sodium. Why is there all this sodium here that's going to end up as part of the urine? And what it will do is it will communicate with the afferent arteriole, which is a blood vessel here that brings blood into that glomerulus, remember that ball of capillaries, it looks like a ball of yarn. It's going to tell that afferent arteriole to constrict. If this constricts, this afferent arteriole that brings blood and subsequently everything that's going to be filtered into the nephron, if this constricts, less blood can move through because it's a narrower pathway. If less blood moves through, then we filter less of it and we reduce the amount of filtrate and therefore what we are losing in the urine, water and sodium. Again, this is under normal circumstances. This is the body's method of controlling how much water and how much sodium and chloride is going to be lost in the urine. This image here shows you, and this is just zoomed in on that distal convoluted tubule, but it's showing that under normal circumstances, that distal convoluted tubule where those macula densa cells are is actually located in close proximity to that afferent arteriole. So just to help you orient yourself, it's not shown here, but this is what would be the glomerulus, that big ball of capillaries that is also here. And this is the afferent arteriole that would bring filtrate, or I should say blood in to produce filtrate. But you can see how close in proximity the macula densa cells are as part of that distal convoluted tubule to that afferent arteriole. In other words, if we sort of fold this around, this area here would be in close proximity to this afferent arteriole here. And so these macula densa cells then are picking up changes in concentration in sodium and chloride that pass through this tubular fluid, will send feedback, which we call tubuloglomerular feedback. It's feedback from the tubule at the distal part to the glomerulus here, causing changes in the diameter of the afferent arteriole. I gave you the example of constricting when there's too much sodium, but if there's not enough sodium here, then it can widen or dilate. And if it widens or dilates, it's going to now allow more blood to flow through, increasing that glomerular filtration rate so that we can get rid of potentially more ions and fluid. Now, how does this relate to loop diuretics? Well, loop diuretics can actually inhibit these macula densa cells and not allow them to function normally. In fact, it confuses them into thinking that there is actually a reduction in sodium. And so because it's not feeding the correct information back to the afferent arterial actually widens. And when the afferent arterial widens, we end up with an increase in the flow of fluid from the afferent arterial into the glomerulus. So from here into here, getting rid of even more sodium and more water. So the net effect here is going to be an increase in the amount of sodium and an increase in the amount of water lost in the urine, bringing blood volume and blood pressure down. However, there are side effects related to reduction in potassium, calcium, and magnesium in particular, as well as what we discussed being the risk of alkalosis because of loss of hydrogen ions. And so it's going to be very important that people that are on loop diuretics, especially if they're on it long term, that all of these things need to be monitored. You need to monitor ion concentration and ion loss and stay on top of this and supplement as necessary. All right, I know that was a lot on loop diuretics, but we're moving on to the next one now. So we've looked at osmotic, loop, and now moving on to thiazide diuretics. Thiazide diuretics are really important in managing blood pressure and sometimes even bone health, as you'll learn soon. Thiazide diuretics are going to be working at the distal convoluted tubule, so shown here in this image. It is the distal part of the convoluted tubule that, remember, handles that fine tuning specifically of sodium and chloride reabsorption. Now, it's important to know that thiazide diuretics are used when the kidneys are functioning normally. So somebody has normal kidney function, a thiazide diuretic could be beneficial for bringing their blood pressure down. If they have kidney disease, though, this would not be the choice of drug. It just wouldn't be effective. Now, how do these work? The first thing I want you to make note of that's very important is that thiazide diuretics act as competitive antagonists. So that means they're competing for a particular site and blocking it. Now, what site is that? Well, if we look at this image here, I want you to note this cotransporter. This is the sodium chloride cotransporter, the NCC. And what this transporter does normally, and this is really this area here is the zoomed in part of here, the distal convoluted tubule. What this cotransporter normally does is at a 1-to-1 ratio, it's going to actively physically move sodium and chloride into the cell. And then from there, sodium can be brought into the blood. And as you can see, chloride can be moved in as well. Normally, when chloride binds to its receptor site, then sodium will, and as I mentioned, 1-to-1 ratio will be pumped in. But what thiazide diuretics will do is they will block as a competitive agonist. Let's say the chloride binding site is here. It's going to block this. And so if chloride doesn't bind, neither does sodium, leaving both sodium and chloride in the tubular fluid, becoming part of the urine and bringing water with it, helping to bring blood volume down and blood pressure. What's really neat about these thiazide diuretics is that where they have their effect in the distal convoluted tubule, the excess sodium that's present here actually encourages the movement of calcium back into the blood. And if we're adding more calcium back into the blood, it is available for storage in bones. And that just comes down to the body trying to maintain its electrochemical balance in this area. And so it's very favorable then, in this case, to be moving calcium into the blood. Also, not just for bone health and muscle and nerve health, but less calcium in the tubular fluid is also good for people that might be prone to the development of kidney stones, which are made up of calcium. Thiazide diuretics can also lead to hypokalemia, and it's really for the same reasons that I described with loop diuretics, where in the latter parts of the nephron, the more distal parts of the nephron, this is where the body's trying to compensate, and it says, okay, well, let's just reabsorb some sodium here then, since we didn't do it earlier. And it does so, but it exchanges some of that for potassium, as we've talked about that exchange before. And so we get more potassium loss in the urine. So it can be a little bit of a snowball effect if you're not careful. And then, of course, just like we spoke about earlier, there can be a state of alkalosis for the same reasons, losing those hydrogen ions from the blood and putting them in the urine. And then if you look carefully here compared to here, we can see that we have that increased calcium loss with loop diuretics, but increased calcium absorption with thiazide diuretics. So great for bone health or people that might be at risk of osteoporosis. The last thing to mention on this slide has to do with this graph, and it's comparing the loss of sodium chloride with thiazides versus loop diuretics. Now, because loop diuretics act on that thick ascending limb, remembering that this is where we get a bigger chunk of reabsorption of both sodium and chloride, they tend to go together. Because there's a decent chunk of this, about a quarter compared to the distal convoluted tubule and the collecting duct, it should make sense that based on where these drugs act, loop diuretic acting on that distal convoluted, on that ascending limb of the loop of Henle versus thiazides acting on that distal convoluted tubule, that is the main reason for the difference in how much sodium chloride is going to be excreted. Moving on to the final one, so now we're on the potassium-sparing diuretics, also known as aldosterone antagonists. First thing to know is that it is common for thiazide diuretics and potassium-sparing diuretics to be used together. The purpose of this is to get the benefit of the diuretic, which is getting rid of necessary ions and water to bring blood volume and blood pressure down, but also try to reduce the amount of loss that occurs with potassium, because potassium is a necessary ion in the body. Potassium is important when it comes to heart rhythms, heart function, nerve signals, muscle function, fluid balance, pH levels, and so on. So if you can spare it, that's beneficial. But you might be thinking, well, we know that we have this loss of potassium with thiazide diuretics, but what about the loss of potassium that we also see with loop diuretics? Are potassium-sparing drugs also used with loop diuretics? Potentially, but for the most part, no, because of the already pretty exaggerated and potent response that you see with loop diuretics. And so putting the two together is oftentimes not tolerated, as well as combining thiazide and potassium-sparing diuretics together. These drugs are going to primarily work in the distal part of the nephron, focusing quite a bit on the collecting tubule. So that's this part here, where we start to get a lot of collection of what will become urine. These sorts of drugs tend to be used in people that are suffering from some sort of cardiovascular disease, such as heart failure, or maybe they have hypertension that tends to be a bit resistant. As we'll see, this drug can also be used on people that have too much aldosterone, and we'll talk about a little bit about aldosterone and its relevance to these drugs shortly. There are two main types that we're going to talk about in terms of how they work. We have aldosterone blockers, and then we have what are called epithelial sodium channel blockers. In looking at this image here, so we're at the collecting tubule, the most very distal part of the nephron. Aldosterone, a hormone, can bind to aldosterone receptors and promote the expression, or really the formation of, both epithelial sodium channels, which when those are formed, then they would embed themselves, just like this one has, in the plasma membrane, allowing for sodium to enter the cell from the tubule fluid. Aldosterone will also encourage the expression of sodium-potassium ATPase pumps, as shown here. So once that sodium comes in, then it can be pumped out. And what this does under normal circumstances then, if you remember what aldosterone can do, is encourage the movement of sodium from the tubule fluid into the cell and then into the blood, also bringing water with it, increasing blood volume and increasing blood pressure. So if we block this with an aldosterone blocker, then we're not getting the same level of expression happening. We're not getting these channels and these pumps embedded or formed and embedded into the plasma membrane. And so what that does is it prevents sodium from entering the blood, keeping it in the tubule fluid. If we keep it in the tubule fluid, water will follow, and then we'll have reduction in blood volume and blood pressure as a result. The other option would be a epithelial sodium channel blocker, and this is actually going to directly block this channel. So if we block this channel, we're keeping sodium in the tubule fluid, water follows, more urine, less blood volume, less blood pressure, reduced blood pressure. Remember on the earlier slides, I had spoken about how you can get some compensatory mechanisms set up in the distal part of the nephron where the body's trying to compensate for what's happening earlier on where those drugs are acting. But what we see, and because of that, it can lead to loss of hydrogen ions and loss of potassium in the urine. But when it comes to potassium-sparing drugs, primarily because we're working at the most distal part of the nephron, we're already blocking what's happening here, so we don't have those compensatory mechanisms in place. And so the body doesn't tend to lose the hydrogen ions in the same way that it normally would, or the potassium ions in the same way that it normally would. And so this can cause the opposite effects. Now, because we're not losing as much potassium as normal, can lead to hyperkalemia, too much potassium. And because we're not losing as much hydrogen ions as normal, and they're remaining in the blood, makes the blood more acidic, and there is some risk of acidosis. So it really comes down to where the drugs are acting, for one, at what level of the nephron. And it also comes down to electrical gradients, maintaining electrical gradients. So because at the distal end of the tubule, we're blocking the movement of sodium, so it stays within the lumen. Now we aren't having that natural encouragement of potassium entering the urine, being exchanged for sodium, as well as hydrogen. Because these guys aren't encouraged to enter the tubule fluid, they instead remain in the blood, all intending to maintain this necessary electrical chemical gradient. So that's where we're not losing the same amount of potassium that we normally would with the other diuretics.